And today I decided to address a question that many patients have been asking me, which is about neck lift surgery. This here is an image that shows what we have underneath that volume in the neck. So these patients who have a fuller, heavier neck often think that what they have is excess skin or excess fat. But actually, the skin is just a container. It's not the cause of the problem. And fat is only a small percentage of the content we have inside the neck. In fact, when we look at a bulky neck, what we're really seeing is the herniation of these deep structures that you can see in the image on the right. So there we can see the sheath of the digastric muscle, and we can see the submandibular glands. We can see the strap muscles of the neck. And of course, there's that layer of fat that sits on top. And we also have a bit of excess in the platysma muscle. So what's the message that this image gives us? In order for us to reduce this volume, for us to achieve better definition in the neck, it's an illusion to think that if we just do chin liposuction or if we simply remove skin, we will achieve this kind of result. In reality, what we need to do is reduce these deeper structures. And only then will we need to reshape all those more superficial structures, like the platysma muscle, and remove any excess fat that may be present. And of course, we will adjust the skin, and any excess skin will be removed at the end of the surgery. Another detail that's also very interesting for us to talk about is what exactly is the so-called platysma band, which we always talk about. We're going to treat the platysmal bands, the platysmal bands. The platysma is this very thin muscle that wraps around the entire neck region. And it's like the structure that shapes our neck. That's why, depending on how we treat the platysma, we'll get a different result in neck surgery. And in the image on the left, you can see how patients perceive the platysma bands. The platysma band is this thing that looks like a little nerve, as patients describe it to me, that appears in the neck area and is nothing more than the edge of the muscle. Every time the platysma is hypertrophic, every time it's redundant, and every time it's loose, we see these little cords, these little nerves in the neck, which are the well-known platysmal bands. And so, when we perform neck surgery, part of that procedure is treating these platysmal bands. So how do we treat the neck? The classic incision for a neck lift or deep neck for any approach we take to the neck is this one here. These are incisions located below the mentum, below the chin, and they are about 3, 4, or even up to 5 centimeters long. Its position in relation to the neck varies quite a bit. I myself change the position of my incision. When I need to remove a gland, I make it a little lower, and when I'm just doing contouring, when I'm only shaping the neck structures and treating the platysma muscle, I make it a little higher. This varies a lot depending on what I want to do with the surgery and what we are going to address in the patient through this incision. So basically, we are going to address the digastric muscle, which is the muscle you see in the image above. The digastric muscle is a deeper muscle. It lies below the platysma, below the subplatysmal fat, and it runs parallel to the floor of the mouth. We have a muscle in the floor of the mouth called the mylohyoid, and just below it, we have this digastric muscle. When the patient has chin retrusion and hypertrophy of this muscle, if we don't perform a partial resection, the patient ends up with excess volume in this region. That's why it's so important for us to know that it exists and to treat it properly. And in the image below, we can see the shadow of the submandibular gland. And it creates this volume effect both in thin necks and in fuller necks. And the treatment, which would be the partial removal of this gland, is what creates that contour effect in the lateral region of the neck. The removal is done partially. We don't need to completely remove the gland. A lot of people ask me if the patient will have dry mouth after the gland treatment, and the answer is no. The vast majority of patients do not experience dry mouth. A recent study has just been published on the aesthetic treatment of the submandibular gland. The study was just published in Aesthetica, which is a high-impact index journal in plastic surgery within the specialty, and they showed all the pros and cons as well as the possible complications. So what is important for patients to know? There are groups of people with anatomical variations in which removing the gland really impacts the quality of the aesthetic result. And every time I am going to remove the gland, I inform the patient that they will experience a bit more pain in the post-operative period, a bit more swelling, a slightly longer lasting hardness in the neck area, and there is a risk of hematoma. Technically, we need to know how to handle this so that it doesn't happen. Sialocele can occur, which is the accumulation of saliva, right? We cut the gland even when applying Botox to the remaining gland tissue. The patient needs to avoid stimuli that trigger saliva production. We give the patient a complete set of dietary guidelines about what they should not eat after the surgery. But even so, they may still have a buildup of saliva, which is the well-known sialocele. If that happens, we will need to treat it. And the patient can also experience nerve praxias. Praxias are those changes in facial expression that the patient may have due to injury to the mandibular nerve or the cervical nerve here in the neck. These nerves run through the uppermost part of the capsule of this gland. And sometimes, due to the Joule effect itself, from the heat produced by the cautery we use, this muscle can get a bit sore, it can become a little swollen, and it may become lazier on one side or the other. And this will cause asymmetries in facial expressions. This change is also temporary. When it happens, it lasts around 4 to 6 months, but it naturally returns to normal over time. So all these details are explained to patients when we choose to use this type of approach. And regarding the platysma muscle, this is my main approach. This is usually what I do in 90% of my patients, especially in patients with a bulky neck and those who have mandibular retrusion. I make this central plication very tight on the platysma muscle. I keep it very firm and perform a complete section of the platysma and the lateral release. The lateral release is this lateral tension we apply to the muscle so that the platysma itself creates that neck contour that patients like so much and creates those angles, right? Which is what we try to achieve with the surgery. And here are some cases I have of neck lifting. And in this specific case, this is a patient who underwent a deep neck procedure. This is a case of a patient with chin retrusion. Every patient with chin retrusion is a candidate for the deep neck procedure. Deep neck is when I treat all of these structures. Of the deep structures of the neck, the digastric muscle, the gland, the subplatysmal fat, in order to create this hollowing effect. I also perform this lateral suspension, this plication of the platysma muscle to create the contoured angled neck shape. And I always complement these cases with fat grafting to the chin and the pre-jowl area to improve the projection of this region. When you combine improving chin projection with the hollowing of the deep structures, and this strong plication of the platysma muscle, we can achieve extremely pleasing results in the neck angle. And what message do I want to leave with you? That not all neck surgeries are the same. Each surgeon has a range of techniques that they usually use. And I have my own tactics. I have my preferred techniques. I don't operate on every neck the same way. Thinner necks generally don't need a lot of hollowing, but they do need a remock, a very strong treatment of the platysma. And patients who have a retruded chin, whose chin is set back, and who have excess volume in the neck usually need a deep neck procedure because there's no point in tightening the muscles if there's a lot of volume. It's like trying to put tight clothes on a patient with a big belly. We can tighten the clothes, but the abdomen will still end up protruding. And when we perform these neck surgeries, it's the same thing. There's no point in just tightening the platysma. If we don't remove the deep structures, so for patients with retrusion and those with excess volume, it's mandatory to include this step in the procedure. Then any excess skin that's left, we end up removing. But what's important? We don't stretch the skin. The goal of the surgery is not to cut the skin. So forget about those surgeries you see on the internet with those huge scars on the neck. There are scars that look like a T, scars that look like a Z, scars that look like a little fish. Forget about these techniques that involve direct skin excision. They don't work, they leave marks, and the results are extremely limited. So it's not worth it. These are techniques from the 1970s, from the prehistoric era of facial lifting. So if we look in the literature, we'll find scientific articles, but they're completely outdated. So that's the first message. Second message, you notice that at no point did I mention chin liposuction. Chin liposuction still has its place in the sun, but it is being indicated less and less. And today, with the experience I have with neck surgeries, I can tell you that we are going to recommend chin liposuction even less often, because we've learned that the main problem for 99% of patients who lose neck definition is not superficial fat. And chin liposuction only addresses one element of the neck, which is the fat that sits above the platysma. And it will always cause some skin laxity, so you won't be able to solve the problem of excess volume, and you'll end up creating loose skin because every liposuction procedure causes some degree of skin laxity. So we have to be very cautious. And I'll tell you that nowadays, on the rare occasions when I do neck liposuction, I end up doing it open. There are cannulas that we use with the neck layers already separated. They don't need suction to be performed. And in my hands, I have much more precision with them than with closed liposuction. So nowadays, I practically don't perform neck liposuction anymore. And this isn't just my approach. I just got back from Rhino Facile in Florianopolis, and I noticed that more and more colleagues are also choosing not to do neck liposuction anymore, even in very bulky necks, okay? So those were my messages for today. Next week, I'll be back with another topic. I wish everyone an excellent week and see you next Monday. Bye.